Thank you all so much for joining. It looks like we still have people trickling in, but in order to stay on time, I'll go ahead and get us started. We're so excited to share this session today. This is the inaugural session of the Equity Equation, an ongoing series presented by the Institute for Public Health Innovation. This particular session will focus on the American Life Expectancy Crisis. We have some wonderful speakers joining us today, and we're really looking forward to today's discussion. Before we dive in, I wanted to give a brief introduction to IPHI. We are a nonprofit organization founded in 2009. We are one of over 40 public health institutes and a member of the National Network of Public Health Institutes. We're somewhat unique because most public health institutes are statewide, whereas we are regional, serving DC, Maryland, and Virginia. Our work spans individual one-on-one interactions through programs like community health worker programs, all the way to systems level work through coalition building, through councils, and through a webinar series like this. Throughout each of our different program portfolios, a strong commitment and foundation of health equity is woven into all of our work. And to promote and advance health equity, we develop innovative strategies, cross-sector partnerships. We support the public health workforce through training and support, and we work in the space of advocacy and policy as well. Our team on this series includes myself. I'm a senior program manager in our Virginia office, as well as Mike Royster. He'll be speaking momentarily, and I'll allow him to introduce himself. We're also joined by Tetua Esperi, a program associate, and Tara Swami, our intern. This webinar is scheduled for 1.5 hours and will include a Q&A at the end of the presentations. We also are pleased to offer an optional discussion session following that 1.5 hour webinar, where participants can have an opportunity to debrief and engage in discussion around the topics presented. Throughout this presentation, the participants are all muted. However, you will have the option to come off of mute if you stay for the optional discussion. Your questions can be submitted through the Q&A button, which is presented here on the slide. It can also be, you can also share a little bit about yourself, introduce yourself, and share questions through the chat. We will address all the questions at the end of the panel presentations. Today, we are hoping to summarize trends in life expectancy in the DMV region, describe key factors contributing to these trends in life expectancy, discuss social determinants of health in relation to life expectancy, and identify potential policy and system strategies to address these issues and improve life expectancy and reduce inequities. Again, we're so excited to join us. And before we dive into our first presentation, we have a quick poll for you, just to kind of test your knowledge and see where everybody is. I'm going to go ahead and launch this. The question is, where do you think America ranks globally for life expectancy? And ooh, I'm already seeing a lot of answers coming in. Y'all were excited and ready to jump on this poll. Lots of thoughts. I'll give it about 20 more seconds to enter your guesses, or perhaps you know the answer and it's not a guess. Still seeing answers trickle in, about 5 more seconds. All right, and with that, I will share the poll results. So the majority of participants here, the majority of you all ranked us at 23rd. I will turn it over to my colleague, Mike, to answer this question in his following slide. So Mike, please feel free to take it away.
Thanks, Rebecca. And again, it's good to have you all joining us for this initial webinar, part of our Equity Equation webinar series. And so as you responded to the initial question, where do you all think the United States ranks globally for life expectancy? I believe the largest percentage of respondents were for C, 23rd, and then the second largest were for D, for 46. And you all, many of you were actually correct. The United States ranks 46th. nationally in life expectancy. In 2022, our life expectancy was about 77.5 years. Not as many people noted response B, but I will point out that if we had asked this question in 1977, you would have been correct that we did rank number 14 in 1977. And in 2022, we ranked number 46. And so as you'll see through this webinar series, or through this particular webinar, we intentionally wanted to focus on life expectancy because of the issue that we are seeing in terms of the declining rank of the United States compared to the rest of the world. And so on the next slide, we'll explore this a little bit more. Here you see a graph from 1980 to 2022 showing the life expectancy of the US in green and other comparable countries in blue, those countries including many that are high income, wealthy democracies. And as this graph shows, if you click, Rebecca, we'll see the first arrow that in 1980, the life expectancy in the US in green was 0.8 years less than comparable wealthy democracies across the world. Since then, life expectancy in the US has grown at a much lower rate than those similar countries. The next arrow shows that by 2000, the average life expectancy in the US was 2.4 years less than similar countries. The next arrow shows us that by 2010, it was 2.7 years less. And between 2010 and 2019, the life expectancy in the US only grew by 0.1 year, resulting in a 3.8 year gap compared to other comparable nations across the world. In addition, the COVID-19 pandemic resulted in a much bigger drop in life expectancy in the US compared to other wealthy nations. And while life expectancy in the US started to recover by 2001 and 2002, you'll see by the final arrow that the US, according to the poll, has fallen from 14th in 1977 to 46th in 2022. And I think you can go to the next arrow as well there, Rebecca, showing where we stand in 2022 at ranking 46. In fact, we've lost 20 years of life expectancy gains, and now we're not only ranked below other wealthy democracies in the world, such as Japan, Canada, and Switzerland, but also countries such as Slovenia, Austria, and Malta. And so it can be argued that life expectancy in the US has reached crisis status, yet it's likely that the average American is unaware of it, and it does not appear on the radar of the average politician, and it's rarely covered in the news. But this chart clearly shows the progression of how we've fallen dramatically in terms of life expectancy ranking. On the subsequent slide, we can see that in addition to the fall of our ranking overall, racial and ethnic inequities within the US are dramatic. Asian American and Alaskan Native individuals lag behind the highest life expectancy by 17.3 years, and Black Americans lag by 12.7 years. So the implications of these inequities are profound on the personal and societal level. They mean shorter life and less time with families, greater suffering, increased healthcare and overall economic costs to society, as well as the ethical and moral implications of unaddressed yet preventable socioeconomic, racial, and geographic inequities in who has the opportunity to live long, healthy lives. In the US, we value opportunity, we value fairness, but we know that these inequities are rooted in unfair conditions outside of the exclusive control of individuals that shape opportunities to be healthy. And so the question becomes, what does our supposed commitment to these values require of us? And what can we do differently as a society in our region, at the state level, and in local communities to change this concerning reality and ultimately live up to these values? To help us explore these questions, on the next slide, we have the listing of our invited panel of distinguished speakers. They will help us to understand this crisis better how it impacts local communities, and start to identify policies, systems, and environmental changes that target the root causes of America's poorer health overall and the inequities that are large and persistent. Our first speaker will be Dr. Stephen Woolf. Dr. Woolf is Director Emeritus and Senior Advisor at the VCU Center on Society and Health in Richmond, Virginia. Dr. Woolf is recognized nationally for his research and journal publications on the social, economic, and environmental conditions that shape health and produce inequities. In particular, he's published extensively on the decline in life expectancy in the US. He works to address these issues through outreach to policymakers and the public, including testimony before Congress, media outreach, and speaking engagements. Our second speaker will be Amy Wentz. Amy is the Director of Outreach and Engagement at the Commonwealth Institute. TCI's mission is to advance racial and economic justice in Virginia by advocating for public policies. In her role, she strives to form deeper relationships with Black and Brown-led organizations. Amy is also co-founder of Southside Releaf, a community-based organization committed to improving life expectancy and quality of life of Southside Richmond residents. Our third speaker for the afternoon will be Councilwoman Cynthia Newbille. Councilwoman Newbille serves as representative for Richmond's 7th District. She was first elected in 2009 and has been a passionate advocate for her district and for policies that create opportunities for Richmond residents to thrive. Among other community efforts, she established and leads the Healthy East End initiative. I'd like to remind our audience to put your questions in the Q&A, and we will answer them after all three speakers have finished their presentations. And now I'll turn it over to Dr. Woolf, our first speaker.
Thank you, Dr. Royster. I'm going to share my slides now. Hopefully that is working. Pleasure to join you all this morning, or this afternoon, I should say. Can I see a thumbs up if we can see my slides? Yep, okay, good.
Yes.
So let's jump right in. I want to take a few minutes to drill down a little bit more about the life expectancy crisis that Dr. Royster mentioned. This is a different graph that shows the same phenomenon and crisis that he described. The red line is the United States. The light gray lines are other high-income countries, and the dark black line is the average for those countries. And as you can see, the US is a distinct outlier. It's important to remember that these national trends for the United States are the product of trends in 50 states. So we have large disparities in the United States at the state level. As you can see, the Deep South and Appalachian regions have lower life expectancy than other parts of the country. And these kind of geographic disparities occur at multiple levels. So if we drill down and zoom in, we see even more granular differences in life expectancy. This is a map of life expectancy at the census tract level. And you can see this is Virginia, DC, and Maryland, that we have large disparities. If you note, for example, the rural areas of southwestern Virginia have distinctly lower life expectancy than in more affluent areas, such as the suburbs of Washington, D.C. The same is true for Southside Virginia. These gaps in life expectancy can actually be quite large. Here we see a map produced by County Health Rankings, a project of the Robert Wood Johnson Foundation, and you can see the poor health outcomes that we see in southwestern Virginia, Southside Virginia, the Eastern Shore. Now let's take a look at how large those gaps in life expectancy can be. On the left is a map of Maryland, and you can see that there is a large variation in life expectancy between Montgomery County and the suburbs of Washington, D.C., which has a life expectancy of 84.2 years, and on the other extreme, the city of Baltimore, which has a life expectancy of only 71.8 years. So we see a 12-year gap in life expectancy between areas that are not that far apart. In Virginia, there's a 20-year gap in life expectancy between the life expectancy in Petersburg and Arlington County, according to data from the county health rankings. If you zoom in on Baltimore, there's a notorious 20-year gap in life expectancy across the census tracts of Baltimore. On the right is a graphic produced by Capital News Service, which actually shows you the life expectancy of countries that are comparable to the life expectancy of those census tracts. So you can see that in areas like Roland Park, the life expectancy is comparable to Japan, which was a country with one of the highest life expectancies in the world. But in other parts of the city, we're seeing life expectancy values that are comparable for low and middle income countries. In the city of Richmond, there's a 20-year gap in life expectancy. This is a short distance apart between the public housing neighborhoods of Gilpin Court and Westover Hills, which has a life expectancy of 20 years longer. In the city of Washington, D.C., we have a 27-year gap in life expectancy between Georgetown and low-income areas such as Anacostia. So life expectancy clearly varies by geography, but we also see that life expectancy varies across populations. One way we think about this is differences in social class. So shown here on this graph is the life expectancy of Americans by educational level. And you can see that those with a higher education, we live in a knowledge economy, those with higher education experience considerably higher life expectancy than those with limited education. We can also look at differences by race and ethnicity. Dr. Royster showed how widely life expectancy varies by race and ethnicity. This is a graph that's comparing Black and white life expectancy going back to the beginning of the century. You can see over here the drop in life expectancy from the Spanish flu pandemic. But you can, what this graph is really driving home is that there is a long-standing historic disparity in life expectancy between the white and Black population of the United States. I could show similar graphs showing the life expectancy trends for Native Americans, which are considerably lower than in the white population. This reflects the historic legacy of systemic racism, which influences access to health outcomes. And if you take a look at the intersection between population groups and geography, we see even more stark differences in life expectancy. So shown here is the difference between the life expectancy of the female white population in Montgomery County versus the life expectancy among Black males in the city of Baltimore, which is extremely low. This is life expectancy values that we typically see only in low and occasionally middle-income countries, that is being experienced by Black males in the city of Baltimore. So let's take a moment here for a poll question. If you could bring that up, Rebecca. Do I need to stop sharing my screen?
No, I am going to go ahead and launch that poll, and it should pop up momentarily. Hopefully you all are seeing it now.
So the question is, what do you think explains the large differences in life expectancy we're seeing here?
They'll have some answers trickling in. I'll give it about 10 more seconds to enter your response. Looks like we have most people's answers, so I'll go ahead and end this and show, well, more coming in. I think now we have most people's responses, so I'm going to go ahead and end this and share the results.
Okay, so we can see that the majority of the respondents identified systemic racism as a major driver of the differences in life expectancy. Clearly, that's a huge issue in explaining the racial and ethnic differences that we see in life expectancy. 20% of people mentioned access to healthcare. As a doctor, that's something I would also think of, but actually the literature shows us that healthcare only accounts for about 10 to 20% of health outcomes. So our life expectancy is influenced very much by other conditions. Among them, the other factors that are listed here, this is a bit of a trick question. So if we move on to the next slide, we really need to think about, well, what drives these huge differences in life expectancy? This is an excellent graphic that was developed by the California Endowment to sort of contrast how we can have such big differences in life expectancy across geographic areas. And, you know, the famous line that your zip code may be more important to your longevity than your genetic code. So the question I asked you was a bit of a trick question because we really have multiple factors that shape our health. Healthcare is one of them. That's over here at 8 o'clock. But our health is very much influenced by the social determinants of health. Factors like education, economic resources, housing, transportation, air and water. These all influence our health. The conditions in which we live are a more important determinant of our life expectancy than our access to healthcare. Healthcare is important, mind you. I don't mean to underemphasize it, but it's really this combination of environmental factors that shape our health. And access to those conditions in our society is very much determined by race and ethnicity. People of color who have been marginalized historically in the United States have more limited access to these determinants of health and end up with large gaps in health outcomes compared to more advantaged or privileged populations. Another factor that influences our access to these conditions is public policy. Policy decisions affect education opportunities, jobs, wages, housing, affordable housing, access to transportation, healthcare, and much more. So when we think of policy, we sometimes think of Washington, D.C. and Capitol Hill, but increasingly in our society, power around issues that affect our health has shifted to the states, and states have become more polarized in their decision-making, reaching different conclusions about health outcomes, about policies that affect health outcomes. And this has resulted in a widening disparity in life expectancy trends and other health outcomes at the state level. Shown here is an interesting graphic that shows that back in 1990, New York, a state with currently very high life expectancy, had the same life expectancy as Oklahoma. But over time, New York's life expectancy climbed to become the third highest in the country, whereas Oklahoma in this graphic ranked at 45. I think it's about 46 or 47 now. So one of the questions that we're thinking about is what happened in 1990 and what explains this departure in trajectory between the state of New York and Oklahoma? Well, some of it has to do with regional issues, demographic changes. These are states with very different economies, and a lot of macroeconomic changes are different between these states. But a very likely contributor to this divergence between these two states is policy choices, that New York made different policy choices that improved the health of their population compared to policy choices made by states like Oklahoma. We've done a lot of research in recent years looking at the influence of state policies on life expectancy trends. The graphic over here on the left is showing the increasing polarization between the 50 states, with some states moving to more progressive policy orientations and others moving to more conservative policy orientations. In this study led by the sociologist Jennifer Montes, I'm showing you a graphic from that paper, which actually analyzed the degree to which specific policy domains are associated with better life expectancy. And in general, what this study found is states with a more progressive policy orientation experienced larger gains in life expectancy, whereas states with a more conservative orientation were more likely to experience no change in life expectancy or losses in life expectancy over time. And certain policy domains appeared to be very important, such as labor policy, tobacco taxes, the environment, immigration, and so forth. Now, I mentioned state policies, and we've also talked about national policy, but health is really very much influenced by our local conditions. You saw the large gaps in life expectancy that exist across our counties and cities and within our cities. And a major factor that influences those determinants of health are decisions that are made by our local jurisdictions and also decisions that are made at the neighborhood level. Policy interventions that occur in our neighborhoods, in our community environments, have a huge influence on health outcomes. And so in our subsequent talks, we're going to shift our attention to what is being done and what can be done at the local level to try to improve health outcomes and close these gaps in life expectancy. So I'll stop there and turn it over to our next speaker.
Thank you, Dr. Woolf, for that great introduction and overview of, and really a deep exploration of life expectancy and how it affects different demographic groups, and how what we're seeing is really a product of various life expectancies across the states within the US. So at this point, we will turn it to Amy Wentz to talk more about the work that she's involved in Richmond City and continue to explore that theme around how policies and systems shape health outcomes. Amy?
Thank you so much. And Rebecca, I'm going to go ahead and share mine because I was able to get it to work. Thank you for the opportunity to speak with you all today. Dr. Woolf, you amaze me. Hearing the information again just inspires me to continue to do the work that we're doing over here in Southside. So I just want to start by saying, yes, I am Amy Wentz from the Commonwealth Institute. I am the Director of Outreach and Engagement, but today my hat is with Southside Releaf. I wanted to make sure that we explain like how we got here and why life expectancy matters. Let me share my screen one moment. Boom, can everybody see that?
Yes, we can see it.
All right, thank you so much. All right, so the block is hot. This is an overhead view of what's Southside Plaza, which is a area of Southside that has a lot of retail. It used to have a drive-through back in the day, but one thing that we noticed about this picture is there is a lot of pavement and it's super hot. And so we start out with this picture just to kind of show you that while in the past we prioritized big paved parking lots and things like that, now that we have done a lot of research and understand that these things harm us, we're making better choices. We are a volunteer-run organization committed to environmental justice. That is my partner there, Cherie, on the screen, as well as two of our amazing volunteers, Sarah and Melissa. We are a very small force, but we are mighty in our goals of improving health outcomes over here in Southside. So I just want to stop right quick and just tell you a little bit about how we started Southside Releaf. Cherie and I were working on the Richmond 300 master plan. And so if you know about master planning processes, localities throughout the state of Virginia are given guidelines through the General Assembly to create a master plan every 30 or so years for their localities. And so the two of us were happened to be volunteers. I was on the Economic Development Committee. She was on the Environmental Committee. And we were just taking part of the citizen kind of resident process to be a part of informing the plan. We all received what was called a insights report from PDR that had all of these like statistics of each of the districts and facts and figures and a lot of data and research that went along into creating like an assessment of the city at the time. And I remember both of us live in Southside. I live off Broad Rock. She lived off Whole Street. And we were looking at pretty much every category. Unfortunately, the areas that we lived in suffered at the highest rates. And one of the most alarming things that we saw was there was up to 20-year life expectancy difference between the areas that we lived in and other areas of town. At the time, I think my daughter was 19 years old. And it kind of made me look at things a little differently because I was like, wow, her whole lifespan, which felt like a long time, right? I mean, raising her could be eliminated from someone just because of where they live. And that alarmed us, and we were kind of like wanting to unpack that. And what we noticed is that these were areas where there was less access to parks and green space. This is areas where at the same time, and you can see the slide in front of you, that Jeremy Hoffman, our friend over at the Science Museum of Virginia, formerly of the Science Museum of Virginia, chief scientist, was also doing a heat study at the time and had asked Cherie and I to help find areas around town where we could put heat sensors. And we saw that there was an up to 16-degree difference on a hot day between certain parts of the city and others. And I remember walking out, we were just taking a breeze walk down Richmond Highway, Route 1, from one of the warehouses to the nearest bus stop, just to kind of like show that. And by the time we got to the bus stop, we were drenched in sweat. There was no shade, no cover. And then we did the same walk in another area of town that had more tree canopy and more access to shade. And it was just like a breeze walk. So anyways, that is why we created Southside Releaf, because we were noticing that all of these, access to healthy foods, the most travels to emergency rooms for heat-related illnesses, asthma rates, like all of the things that by which the city was kind of measuring each area, the areas that we lived in were suffering at the greatest amount. What we also noticed, and you can see on the screen here, is that the maps kind of also mirror the former redlining maps from back in the day. And so I'm sure you all know about redlining, where certain neighborhoods were deemed unworthy and deemed unworthy of investment, and folks were not able to get home loans and certain insurances in those areas. And if you look at a lot of the documents from back when they were creating the redlining maps, you'll see that it was a direct relation to race. Like even if students traveled through a neighborhood that were Black going to school, they would lower the rating for that particular neighborhood. So when we talk about racism and how horrible policies have affected this, the facts are the facts. This is just also the map, just talking about the Health Opportunity Index, which is another way that the city of Richmond kind of measures how folks are doing. And you can see that the kind of maps also match. So the equity, the climate vulnerability score, and the health opportunity scores are lower in the areas that we serve. And if you see the kind of the 6 and the 8 on the screen, and parts of 9 is where we primarily focus our attention. So we talk about, how and why we got here. That's one of the things that we do at Southside Releaf, is making sure that we educate our community on how and why we got here. And so we talk about annexation, where it's parts of Southside were taken over to preserve the white power of the government in the city of Richmond. And so they would try to get more parts of Chesterfield, right? And then get those voters to be able to maintain that power. And with that came promises of investment and promises, but there was no plan to really make sure that these annexed areas strategically got the same investment as other areas in the city of Richmond. And so we're suffering from that now. Then you had, like we said, redlining. So formerly redline areas that are still suffering from the aspects of those horrible policies. And then came urban renewal, where folks were like, we have these great ideas. We're going to do, we're going to put these warehouses, and we're going to, bring in investment and bring in, economic opportunity, which displaced folks, which, caused harm, because, I don't know about y'all, but when you drive down 95 South, like headed towards Petersburg, and you open the window up, it smells a little different on Southside. And so when you smell something different, what does that usually mean, right? If you can smell it, then you're inhaling something into your system. And so we're dealing with the areas that have the most, factories and like the most areas that put off fumes. So for air quality, we're also part of the Chesapeake Bay watershed. And so our creeks and rivers, creeks and areas that come from the watershed, wanting to make sure that those are, have healthy water and quality water. So the challenge for us is to improve overall health outcomes and the quality of life. And so we want to take that 20-year gap and try to decrease it in our lifetime and in the next and in the next. So we just want to continue to do the work in those areas. How we do that work is in 3 different ways. So the first way is by educating. Like I said, we create opportunities where community members can learn about how we got here and how we can get out of the situation that we're in. We also help with advocacy. So we knock on the halls of power. We talk to leaders. We talk to decision makers about using legislation and policy to be able to create pathways and to getting these solutions done. And then we do our hands-on projects, the planting, the maintenance, and park planning. One of the things that we found in the Richmond 300 planning process is that Southside was lacking the ability to walk to a park within a 10-minute walk or 2 miles of your household. And so we were having issues with finding, park spaces. And so working with conservation groups, land conservation groups, and urban planners to be able to kind of find those areas in Richmond and to advocate for more park spaces, bikeable and walkable neighborhoods, making sure that that folks can travel safely to and from their workplaces, their modes of transportation, including increasing access to public transportation and making sure that our spaces where folks are waiting for the buses have shade, that pathways have shade, and that we're reducing the heat that folks are suffering with. And then like I said, our planting projects. So we do tree plantings, tree giveaways in certain areas. We use the tree equity scorecard that American Forest has created that tells you each area, neighborhood, census tracts, even down to blocks, the effect that certain trees and shading can have on that area when it comes to life expectancy and other measurables. And they also create opportunities to strengthen our communities, right? Anytime we bring a community together, center voices of community and rally around things that are important to us, it's always a great opportunity. We're going to talk about some of our wins. This actually has gotten bigger now. We've planted over 1,200 trees in Southside. We've had over 45 community events. We're planning 5 new park spaces in South Richmond. This is something that we advocated for after the Richmond 300 planning process. And we're in the process of onboarding those new parks. And so we have partners at the Chesapeake Bay Foundation, Virginia Community Voice, Parks and Recreation, Office of Sustainability, Department of Public Utilities, Works. There's a lot of partners that are coming together to really prioritize this. And we feel that it is a win for community, a win for our sustainability plan and the plans for the city. Also created a new urban forester position. That's something that we advocated for. We'll talk about that later in some of the questions, but we saw, we're doing all this great work and there's a lot of organizations doing great work, but there was nobody to kind of shepherd and to guide the work. And so we were able to advocate for that at the city level and get that in the budget. And the city just hired their first urban forester last year who is working with our organization and many to do that. We also launched a Southside Greening Working Group. And what this did was it brought together around 20 individuals from that lived in Southside that kind of knew about greening and kind of knew about environmental climate action issues, but wanted to understand and know more. And so each month we would take on a new topic, whether it's community gardens whether it's urban forestry, whether it was, climate change, whether it was heat related education. So we were able to do that, as well as work with some other environmental groups that have similar working groups to really just expand the education of our community. Because I think like Mike said at the beginning, folks just don't know, right? When you talk about life expectancy, when we say that we were inspired to create Southside Relief because of an up to 20-year life expectancy difference between our neighborhoods and just neighborhoods right across the river. That's alarming to hear from folks. And this is in the data that we share, that the city is making, that's creating policy from. And so it's super important. And then just also, well, we'll actually go over that when we do the questions, but I have some policies that we are trying to, push forward that would kind of help us to maintain some of our urban forest and our spaces. And this was just a quote from Mayor Stoney here with the city that said, with the help of outstanding community experts, we've made an intentional effort to designate the first new park spaces since 1970s in communities of color. And we're asking the community what they want to see in those spaces, thanks to organizations like Southside Relief. So we add that just to tout that we are, partners with city departments and other organizations. We always want to work with folks to help with the cause. And so we add that on there. And then what's next for us, we want to be able to map our projects around town. We also want to create the Southside Master, Greening Southside Master Plan. And what that does is it talks about transportation, housing. It talks about safe routes to school, like combines all of the things within greening that are important to community into one document, into one initiative that we can really fight for in budgets. And when money like ARPA funds and things like that come down, we'll be able to say we already have this tool available. And then the Cool the City campaign. This is just where we educate our community about the benefits and the importance of climate action. Like I said, the benefits of trees, access to healthy foods, being able to walk and bike safely in your neighborhoods, making sure that our students feel safer communities. So there's so many intersections into the work that we do and other advocacy areas. And like Dr. Woolf had mentioned, there's, it's so many different levels that you can, I forgot the word that I was going to say. Sorry, it happens to me all the time. But anyways, yeah, so that's us. That's what we've been working on. And I'd love to connect with you if you'd like to connect. We're always willing and to work with partners and to get new folks joining our cause in our efforts. And like I said, it all goes back to life expectancy and us decreasing that 20-year gap. And it seems like we have more deep work to do on a national level after hearing the presentation from Mike and Dr. Woolf.
Thank you, Amy, for that very interesting, insightful presentation. Appreciate the perspective of your community and the work that you all are doing at the local level that ties to this much broader issue of life expectancy across the country. And as you mentioned, we're very interested in exploring more around how your work, you mentioned the environmental perspective and the environments that you are changing and how that relates to some of the policy and systems priorities that you all may have. So we'll certainly come back to that in the Q&A. And at this point, I'll turn it over to Councilwoman Cynthia Newbille to share her insights with us.
Thank you. And thank you for the opportunity just to share some of what we've been working on in the East End of Richmond, but also what we've been looking at in terms of the city of Richmond to address the issue and mitigate the social determinants of health that undergird the life expectancy crisis that we are seeing. And so what I'd like to start with first, and I'm going to abbreviate this because there are several items that are not included at the end of the presentation that I'd like to focus on. But I'd like to start with a discussion, just sharing with you a current initiative that's underway in the East End of Richmond. This is something that was initiated, the discussions launched with community partners in 2021, but certainly in partnership with VCU Health System, Cheryl Garland, and this is the Healthy East End Initiative. We looked at, and we'll go to the next slide, Dr. Woolf, the data that was produced that certainly bespeaks and continues to just provide a even more urgent and compelling need to develop appropriate responses to what we're seeing when we see a difference of 20 years in life expectancy for such a short distance from Gilpin to Westover, from Fairmount to Westover, 16 years, 14 years from Swansboro, that urgent and compelling data set and understanding of the crisis that we are confronting here in terms of life expectancy in the city of Richmond necessitated us looking at, in this moment, a initiative to, and if you go to the next slide, initiative to address how we might work collaboratively and collectively to increase life expectancy for residents who live in the highest disparity census tracts. And so we have been in those discussions. We have established a steering committee and adopted a charter in the summer of 2022. And I'm fast forwarding because I want to get to, and I'm not, yeah, okay. And so for us, and this is an effort that Cheryl and I are collating, it was important to bring together community organizations, public agencies, private partners, and especially East End residents, with that steering committee being overwhelmingly East End residents, to collectively address what we saw and see as systemic social, economic, and health issues that have historically been drivers of health disparities and inequities that we see across our community. We believe that a community-led approach builds trust and is going to be critical to the implementation of any initiative that really gets at the root of the social determinants of health that underlie life expectancy numbers that we see. You can go to the next slide. And I'm going to go swiftly through the next set of slides because what we wanted to do in the East End was to take a look at this slide. Gives us, we looked at census tracts across the East End. What's highlighted here in pink are public housing communities. If you go on, next slide. We dug in and looked at mortality summary data by census tracts because we wanted to make sure we were focusing on those census tracts that were most directly had the highest incidence of mortality and morbidity, so that we could create an opportunity for a pilot to really focus in and to try to address what we're seeing. And so census tract 204, we looked at population, number of deaths, we looked at a number of avoidable deaths, all causes of death, etc., across the table here, if you go to the next slide. We looked at the leading causes of death in the East End, and so you can see there with cancer and heart disease at the top there, and the other areas, and I'm going swiftly through these. If you would go to the next slide. We looked at avoidable mortality definitions and information, preventable causes, as well as treatable causes. For us, we had too many people dying too early, too often from what we consider to be preventable and or treatable health conditions and other conditions that undergird the kind of life expectancy crisis that we see. Next slide. We did a further drill down. I'm looking at age-adjusted avoidable mortality rates, and we looked at the tracts most impacted here, and you'll see 204 in the very dark section of the map there has the greatest age-adjusted avoidable mortality rate per 100,000. And so this particular initiative is a pilot that will focus on Census Tract 204 based on the data that we went through very quickly. But because I want to also share with you some other things that overlay with this effort, those will be the census tracts that we get underway with. Will be the census tract, and we're talking Upper and Lower Mosby and the surrounding area there. As I said, we have established a steering committee. You can go to the next slide. The focus area for us is has been developed based on the conversations, the data review as heart health. We will pilot that the community effort in terms of Census Tract 204. Go to the next slide. And again, so we established the steering committee. We have populated it. 52% are residents from the district. We have obtained project management support for planning year 2023, financial commitment, $50,000 for first year of operation, an agreement to serve as a fiscal intermediary from the Community Foundation. We've developed the work plan, as I said, very swiftly from going through all of the data that very quickly was highlighted to identify both the area of focus, heart health and heart disease, and the pilot for the community being Census Tract 204. We've established committees to implement the work plans. Those are the three committees: finance, operations, governance, community engagement, and data evaluation. We've adopted a budget for the first year. We've engaged a public health intern to assist with the intervention design and tracking of data, and engaged a facilitator to really guide the development and implementation of what we perceive to be critical to any community effort that's going to get at the core of the issues that undergird life expectancy and the social, which are social determinants of health, which is the community engagement strategy. You go to the next slide. Next steps for us, we're looking to identify the backbone organization who will provide support, including fiscal administration for the project, defining the role of AmeriCorps that will be hired by Richmond Health District to support the work in the census tract, and develop and implement the community engagement strategy. Next step. This gives you just an overview of the members of the steering committee at this time. As said, Cheryl Garland and I are the co-chairs right now, but we have included representatives from the community, from our school system, from our faith-based organization, Housing Authority, but especially our resident involvement, as well as other nonprofit entities and for-profit entities. Bon Secours is at the table, on and on. Next slide. And so with that, I know that was a quick overview, but I wanted to have some time. I was trying to be mindful of time to just share with you an initiative that's currently underway, because we know that, again, Richmond's life expectancy crisis is real, and that we needed to while we're looking at policies that need to be implemented, that we also need to have some partnerships and programs that are really targeted and that are giving us information to get our arms around this life expectancy crisis that we see. In terms of policies that began to focus on and I think it was mentioned, and Dr. Woolf, I believe, mentioned before, in terms of the life expectancy and the social determinants of health only about 20% of the are considered to be within the clinical healthcare. Another 30% are health behaviors, and then another 10 physical environment, another 40. So about 70% are non 70 if, and again, I'm just looking at the numbers and it's still pretty stunning. But 70% of our the social determinant of health factors, once you take out the health behaviors, are at the core of the life expectancy crisis that we're seeing. And so in the city of Richmond, I have had the opportunity to work closely with our health district staff persons and the administration to bring forth legislation. We were able to establish the Richmond Health Equity Fund, which had a focus and still has a focus of 7 priority areas: mental and behavioral health, food access, substance use disorders treatment, maternal and infant health, access to care and health education, and other underlying health conditions and other emergent health outcomes where Richmond's populations have disparate burdens. And then, of course, certainly COVID with vaccinations, et cetera. And so we were able, with the ARPA funds, to have $2.5 million earmarked for the Health Equity Fund over 2 years. And so while this seems like a lot, what we know is that we're dealing with generational health issues. We're dealing with a major life expectancy crisis. And so it's going to be more than 2 years, but this lets us get underway with some of those major areas that are social determinants of health. And so you will next slide see, I believe, some of the organizations that have been funded thus far, and they are really organizations that are in community, able to be easily accessed, to have impact in terms of access to care, access to food, mental health, behavioral health, and communicable disease. And so the Health Equity Fund is the only one in the Commonwealth of Virginia to date. And I'm hoping that more will come, because this allows us to really get our arms around some of those social determinants that undergird this crisis that we are evidencing. I'd like to share with you, in addition, it becomes critical in terms of policy that housing is a major component. And so in the city of Richmond, and the Health Equity Fund is City of Richmond policy that's been initiated, implemented, and that council has committed funding to. Similarly, because housing is so critical, there is the Affordable Housing Trust Fund, which funds have been earmarked for $2 million in ARPA funds, but another $50 million recently in partnership with Local Initiative Support Corporation, as well as looking at the provision of supportive housing and housing for homeless families, because housing is a critical component in terms of addressing the social determinants in life expectancy. Employment becomes critical. So we have established our Office of Community Wealth Building, which is focused on creating employment options and opportunities for residents. We have similarly, with transportation as a major component, and so made sure that fare-free transit is available for families throughout the community. We have also looked at environmental conditions and working to make sure that some of what Ms. Wentz really, just so aptly described in terms of the heat islands and where those are, and they overlay with the life expectancy numbers that become critical in discussion. And so environmental, and we're looking at that in terms of tree plantings throughout the community as well. And so when we talk about the health, we talk about life expectancy, health. We're not merely talking about the absence of illness, but the active promotion of physical, mental, economic, social, educational, environmental, community health and well-being. And so what I'm pleased about, we still have a long way to go, is that City Council and administration have worked collaboratively to initiate policies that help us to address many of the social determinants of health. Like I said, whether it's the Health Equity Fund or housing or employment, economic development, transportation, environmental issues, public parks, I think was referenced, and just having that green space available for that impacts the overall mental health and well-being, was a significant investment in parks, but across the city to create that resource. And it's not a nicety, it really is a necessity in terms of improving health and well-being. And so I have too many papers here, Dr. Royster, and so I'll stop there. But there is, before stopping, there is critical need for partnerships to address this crisis, but also policies to address the crisis. And the partnerships yield programs that hopefully will better inform us in terms of how we get our arms around this incredible disparity we're seeing in terms of life expectancy. I mean, it is, so with that, I'll just stop there and just, because there's more, but I'll hold right there.
Well, thank you, Councilwoman Newbille. Greatly appreciate your presentation, your insight, and the clear passion that you have for this work. We are now going to move to the question and answer and really discussion aspect of our, do we have a poll for?
If we have time, there was a question I know our panelists were interested in hearing from the audience about how you prefer to be engaged or to engage communities you work with in policy and advocacy work. And if you have some thoughts on that, we'd love to hear your responses in the chat, or see your responses rather.
Yeah, so feel free to share your thoughts, your insights, both your experiences as providers and as members of communities who have an important voice to share in shaping policy. And as we continue into the Q&A, we will check back on those responses and incorporate those into the conversation. And I do also want to remind you all to please, if you have other questions related to what the panelists have shared, please drop those into the Q&A, I believe, or is it the question and answer area, and we will incorporate those into our conversation. And so first, while that's happening, I do want to ask a question of each of our panelists to get us started and to really get us thinking more in depth about what they've shared. And Councilwoman Newbille, if I can begin with you, since you've just finished your presentation and your insights are most front of mind for folks. You mentioned a number, first of all, the Healthy Easton Initiative and the Health Equity Fund, and the important roles that those play in your community. You also talked about a number of other policies that the city that you have championed, as well as other folks in City Council and city leadership. So I want to get your insights into how you've been successful in doing that. And we have other questions where we'll kind of explore the challenges of this. But I guess based on the very interesting and exciting things you talked about in terms of housing, Office of Community Wealth Building, fair, free transit, and other policy issues that you and your colleagues have effectively championed. Can you talk more about how you all have been successful in doing that? And also, do you have any insights that you could share with other elected officials who are interested in moving similar policies forward?
Yes, I think that one of the things that's always paramount, and your organization, Dr. Woolf, Derek Chapman, looking at the data here, we're all committed to improving the overall health and well-being of our community. And so really understanding what our health status is. Based on that, it really has been an opportunity to then partner based on the information, the reality, not what we think, but the reality. And when you can have data down to the census tract in our communities, when your zip code is defining the health, that having that data, then having the opportunity to work with our partners, the health district, the health systems, et cetera, to discuss what are the opportunities and options and best practices that we see out there that are working. We don't want to keep doing what we've been doing because that's not worked for us. But the extent to which we can partner and collaborate is going to be critical, and have policies that then support that and provide resourcing, both public sector resourcing, whether it's local, state, or federal. In the case of ARPA, certainly, and in the case of the Health Equity Fund, certainly ARPA was just critical with that start. But to make a long answer short, it's really the collaborative partnerships, hearing from them in conversation with community voices, and understanding. We have resource centers in each of our public housing communities, for example. And so having information come back to us, because we got that information from community health workers. What are you seeing? The VCU Health Hub, that's an entity that's right in the community. Bon Secours, and so resident informed partnerships, and then being able to look at best practices and deploy, to identify policies, deploy resources to get underway to try to get our arms around as swiftly as possible, and to as swiftly as possible to address the health challenges before us. Again, we have too many still dying too early, too often, from what is absolutely preventable and treatable health conditions. But the success has been with all the voices at the table. So the partnerships, the community, the philanthropic entities, academic partner, everyone at the table coming together to look at the challenge before us in terms of overall health and well-being. That is a much longer answer, Doc, than you wanted. It is, we've been looking at this. This gets to be not rocket science. And I'm saying, come on. So it's obvious that we all have to get to the table, and we can't do it without authentic community voice. We can't do it without all of the other partnerships coming together to really lean in and work collaboratively to develop programs, policies, funding to undertake the efforts. So.
Thank you, Councilwoman Newbille. I appreciate that response. And sounds, just summarizing, you talked about data, best practices, partnerships, community voice, all leading to those policies and programs that will make a difference. I want to go now to Dr. Woolf, if I can, and I want to kind of connect something that you just said, Councilwoman, around this not being rocket science. And knowing, Dr. Woolf, that you have been publishing on this life expectancy crisis and giving testimony talking with folks around the country, I wanted to get your thoughts on why this issue is not more widely recognized or at least acknowledged, and why there isn't that effort among policymakers, among decision makers, to really focus on this as what I would call a crisis that we're seeing in our society. Yes. And just as to tag on to that, I also wanted to just see if one of our audience members asked just if you could define how life expectancy is measured, so we can kind of see how it's measured, and then kind of connect to that question that I just asked about why it's not seen as an issue.
And do it all in 3 minutes. So very quickly, we don't have time to go into the weeds about how life expectancy is calculated. What it is not is a prediction of how long a baby is going to live who lives in one of these neighborhoods. We can't know that because we don't have a crystal ball. But if I wanted to describe to you how high mortality rates are in these neighborhoods, I would send you a detailed table that shows the probability of dying for infants and for ages 1 to 4 and 5 to 9 and 10 to 14, all the way through to old age. Rather than sending you a detailed table like this, I could give you a composite statistic called life expectancy, which is a summary measure of how bad the mortality rates are in that area. And Councilwoman Newbille showed you data about the high mortality rates that are in these census tracts with low life expectancy. As to why it doesn't get more attention, to some extent, the most courteous explanation is that people don't know about it, and more efforts need to be made to raise public awareness. I'd call attention to a recent series in the Washington Post that has tried to bring more attention to this issue of low life expectancy. But it also runs counter to American beliefs in exceptionalism, that we are the best at everything, and data showing that our country is doing worse than other countries is often not a popular thought. And many of the solutions that we've talked about in our increasingly polarized policy environment are resisted by interest groups that are opposed to the kinds of policy solutions that would improve life expectancy. Incorrectly, many of them are viewed as socialist or a far left liberal agenda, when in actuality, many of the strategies that would improve our life expectancy are core issues like improving economic opportunity, bringing back middle-class jobs, improving access to education, and many of the other policy efforts that you've heard about during the webinar. So in the interest of time, I'll stop there.
Thank you, Dr. Woolf. I appreciate that. And we'll, I think, hopefully have some time to come back to that insight as well. And for now, I want to go back to Amy, because as she kind of alluded to in her presentation, that we did want to come back and talk more about some of the policy and systems level priorities that they've had. And, particularly thinking about the focus of their work on life expectancy and heat islands and the built environment and all of that. I really am curious, Amy, if you could talk more about what are some of the most important policy and systems level issues that you all are trying to address or have addressed to help support this effort that you all are leading through Southside Relief?
Yeah, thank you so much for the question. So like I said before, one of our biggest buckets is advocacy work, and we understand the need to kind of push policy so that that we can get the outcomes that we need. Some of the things that we're focused on now are some of the tree bills that are at the state legislature. Rachel, I don't want to knock on wood that they're on the way to the House and Senate floors, and we're hoping that they will be successful. But what they do is they make developers or folks that are developing certain areas that remove trees to be able to sustain them. Maybe I think keep 30% of the trees intact, and then if not, to be able to plant more. So just having that in actual state law. Right now, it's kind of free for all. Folks can do development, and they're not held to any specific standard unless a locality makes that. And so this will be a law that could affect all localities that will have to come up with a plan to make sure that developers are doing that when they're taking up precious urban forestry and removing that. Some of the other things, like I said, that we're working on are conserving park spaces, and so making sure that zoning is covering park spaces and protecting them, and so that they can't be used. There's a lot of like language that allows localities to be able to use certain areas for things if it's deemed necessary for the public. But there's like little language there that kind of gives them a way out, and so we just want to make sure that we are removing that language and allowing public spaces to really be protected, and especially in our quest to kind of expand those. The other thing is just centering people in policy decisions, centering the impacted. One of the things I love about what Dr. Newbille was talking about is in her initiative, there's an advisory council of folks that live in those areas. And so we always want to push for policy and push for decisions to be made, because we know that the closest folks that are closer to the problem are closer to the solution. And so we definitely push for people-centered policy planning, development, and just making sure that we're bringing folks along as we're pushing for this. Yeah, does that answer your question, Mike?
Yeah, definitely. Thank you. Thanks. So I want to now I'll check with Rebecca and see if we have a question from the audience that you'd like to share.
Yeah, we have a number of questions. I'll start with one that I think we've touched on in a certain way, but might be good to kind of circle back to and have each of our panelists reflect on. So this question is about the social determinants of health and the structural determinants of health. People often talk about how stubborn the social determinants of health are. So how can we get off that hamster wheel if we are not addressing the structural determinants of health? So again, the question is, how can we address the structural determinants of health to budge the social determinants of health? And I
Well,
will
let me
open
jump
that
in to clarify what we typically mean about structural determinants of health. And that is that there are policies and systems built into our institutions and organizations in our society that affect the determinants of health that we've been talking about in this webinar. So to use an example, we can talk about differences in educational attainment based on race, ethnicity, and social class. And there I'm referring to whether somebody's had a high school diploma or gone to college. But there are structural factors that determine our access to education. And those range from issues in the classroom as to how teachers handle students and implicit bias in disciplinary suspensions, to what happens in the principal's office, to what happens up at the superintendent's level with school districts, and then all the way up to the state and national policies around education. And throughout all of those layers, we have policies that systematically disadvantage students of color and low-income students in a way that produces these educational disparities. So the person asking the question is getting at a key point. We're not going to close the gap on those educational disparities unless we address those structural factors.
Thank you for that insight, Dr. Woolf. And I think really it connects to kind of the theme that we're trying to reinforce here, that ultimately the policies and systems level interventions that shape the social determinants of health, in essence, and shape who has access to those, are really at the root of trying to promote equity and improve life expectancy. Anything that our other two speakers would want to add?
For me, that was, I think Dr. Woolf summarized it well. I don't have anything else to add there. Yeah, I think that was a great summary.
And Rebecca, maybe we have time for one more question.
Sure. This question is directed at Cynthia, but I think any of our panelists could chime in. This question asks, how were the 7 funding priorities identified for the Health Equity Fund? There are so many impacts on health. How did you narrow it down?
Okay, so there were a combination of things. This was at the time that we were in the midst of the pandemic. So some of that was driven in consideration of what we were seeing in terms of major disparities and just the disparate death rates that were occurring. So COVID and the need for vaccinations, that was, just absolutely critical. What came out of that in terms of impact on mental and behavioral health, the whole virtual work. So we looked at the environment in terms of, again, coming out of coming out of it to whatever extent we can say we came out of COVID. I'm not sure that that's accurate, but we took a look at what the harsh realities were in terms of the health conditions in our community that were still, just really most blatant in terms of social determinants. And so COVID, social determinants, things that other kinds of things, opiate epidemic that was going on, the rise in terms of maternal and infant health. We listened to and looked at data in the community broadly. We, certainly had benefit of our health department. We had benefit of, again, the data that was collected. We had benefit of absolute conversation and engagement with the community. So we knew food access was still a challenge. So while you might not think of that as something that would be a part, it is a challenge. So there were a combination of factors that went into establishing the funding priorities. And with the very last bullet, we also knew that there would be other underlying health conditions that might not get picked up in those categories delineated above. And so we still wanted to allow that there may be some emergent conditions that would need to be addressed. But great due diligence was done looking at the health of the community, the data before us, what came out, and what we learned from COVID, the impact and implication for children, youth, and families, et cetera. So that was a pretty long pretty long answer. I know I'm not noted for being brief, and I'm really trying hard, but it's not working well. I have papers all over the desk, like, okay.
Well, we know that there's a lot on your plate and a lot that you're focused on improving, and we appreciate it. And unfortunately, we're out of time for additional questions, but appreciate the responses of our panelists and appreciate those who shared questions. And unfortunately, we have not been able to answer all of those. But we certainly hope that this has been a valuable webinar for our audience and that you have not only learned a great bit, but that it has inspired you to continue the work you're doing and possibly re-engage and become even more intentional about your work to promote equity. I also obviously want to thank our panelists, Dr. Woolf, Amy Wentz, and Councilwoman Newbille for their insights, their expertise, and most importantly, their passion and commitment to this work of improving life expectancy and equity. As we mentioned in the outset of the webinar, that the title Equity Equation is there for a reason. We're focused on data plus community plus policy, all of which are essential to advancing health equity. And so we encourage each of you to be intentional about integrating the equity equation into your spheres of influence in order to make sustained changes that move us closer to living up to our values of fairness and opportunity to give everybody the chance to live a long, healthy, thriving life. I want to acknowledge the IPHI team, Rebecca, Tetua, and Tara for their behind the scenes work, as well as Nick that made this webinar successful. And I'll turn it back over to Rebecca. And again, thank our audience for joining us today.
I just want to echo Mike's words of gratitude for all of our speakers and the team that helped put this on. This is just the first of what will be several ongoing installments of the equity equation, where we will continue to dive deeper into policy issues impacting the DMV area, public health issues rather, and policy solutions. So from here, we'd like you to visit our website for additional resources. You will also see a post-webinar evaluation pop up at the conclusion of this webinar. Please take just a minute. It's very brief. It will help us fine-tune future webinars. We'll also send a 6-month follow-up to see how you've utilized the information that we presented today. And again, that will help us continue to develop future educational opportunities and ensure they're serving our communities. We also want to talk a little bit about the next installment of the equity equation. For Black Maternal Health Week, we do plan to have another session on Black maternal health. So stay tuned for the date and information about this presentation. I want to mention again that following the formal conclusion of the webinar, if you would like to participate in a discussion session, please stay on the line. We will not close the webinar. We'll simply wrap things up, and we will provide everybody the opportunity to debrief, come off of mute, and talk for a facilitated discussion. So that will be starting just momentarily. Again, thank you so much for joining us. I've included our email on this slide, so please feel free to reach out to us if you would like to ask a question. I know we didn't get to all of the questions, so again, please feel free to reach out to us. We will send the slides and the recording following this webinar today, and we will also share some resources for further reading. So with that, I will thank our team. I'll thank our presenters, and just have a note that that you can stay on the line, and around 1:30 we'll start a facilitated discussion if you'd like to participate in that activity. So thank you all.
Thank you.
So thank you for everyone who stayed on the line. I want to just give some housekeeping notes about the discussion session that we're planning for the next 30 minutes. As I mentioned, we're going to just stay on this line, and there's no need to click any additional links. We will have the ability to let you come off of mute if you raise your hand. So our staff and our team will be monitoring this. And if you'd like to participate, to say something, simply raise your hand and we'll take you off of mute. You're also welcome to continue using the chat. We prefer the chat over the Q&A at this point. So if you're able to use that chat, we would really appreciate it. So thank you so much for staying on. We'll let this session really be guided by you. We have a few questions to kind of get us started and to be thinking, but we are really interested to hearing from you and collaboratively debriefing this session. So with that, I will move into our first question. Thinking about the data, experiences, and insights that our panelists shared, what stood out to you the most? What surprised you? And I know that seeing the chat and the questions, there was quite a bit. I'll just share my personal experience first. Right off the bat, I was really struck by the national numbers that Dr. Woolf shared. And I think one thing that really stood out to me was looking at the chart of New York and Oklahoma and seeing how much divergence and difference that was over time, just based on policies and approaches. So I really appreciated that and was struck by that. And David, I have unmuted you, so you should be able, I have given you the ability to unmute yourself. So if you'd like to provide a response, please go ahead and do so.
Thank you. Thank you to all the panelists. Good afternoon, everyone. I contributed a chat earlier. I'm David Palms. I'm at the DC Primary Care Association in DC. And I wanted to just share briefly what I mentioned and then also ask a question. So I'd love to hear about the project that Councilmember Newbille you're doing. And I shared a link to a project that we did in DC, in DC's Ward 8, which shares many characteristics and is probably about the same size as the neighborhoods that you're looking at, or maybe slightly bigger or smaller. I'm not sure. It's about 70 to 80,000 residents in the district's 8th ward out of 8. And we did a big survey. We convened a lot of organizations. We were not the leading organization, but we were sort of a founding partner organization for a Ward 8 organization that has been set up, focused on the linkage between health equity and community development in particular. The area is expected to be developed significantly. So we tried to put together in our report, which is available on the website that I linked there. It's w8ced.org. Use of this Cantrell's ladder measure, which we think is a well-being measure that correlates to life expectancy. And so we're really trying to use that as a baseline for, how do we begin to improve life expectancy and measure that, even though life expectancy is a pretty lagging indicator in and of itself. And one of the things that we're hoping to do with that, and this leads into my question for Dr. Woolf, is, as we try to improve what the healthcare system and the public health system can do, we're interested as the Primary Care Association, working with all the community health centers in DC, in how does the next generation of insurance contracting, MCO contracting, value-based care that everyone talks about, how do we actually get some of these dollars to be invested in these things like what Southside Releaf is doing, or the things that are being identified in the neighborhoods that Councilmember Newbille as priorities. Like, there's so much money that is spent on tertiary care once people are sick, but what do you see as the most promising areas for loosening some of the pockets and getting money into the right places for preventative primary care? Thank you.
Thank you so much. I'm glad to hear that others across the region are using life expectancy and other metrics to drive policy, to drive changes on a community level. Unfortunately, most of our panelists have hopped off at this point, the formal conclusion of the webinar, but I believe Amy might still be on. And you kind of mentioned how they, at Southside Releaf, have been able to use this data to develop, through community engagement, develop a plan and act on certain initiatives with others that are kind of lined up on the wish list. So Amy, if you are still here and are willing to tackle this, I know this is a question everybody has on their mind, the funding aspect.
No, I'm glad that you all mentioned that. I actually, as a participant in the discussion topic, I moved my hat over to TCI because I'm always interested in the perspective of folks and wanted to hear the questions that come about. So there's a couple of things. So the data that Jeremy Hoffman did at the Science Museum really helped us. And I will say this too. There are a lot of the areas that Dr. Newbille mentioned in the East End of Richmond suffer at the same levels as the areas that we focus on in Southside. And so even though our focus is Southside, they have a lot of areas that suffer from the same issues, same formerly redlined areas, same all of those demographics that we were talking about earlier. One of the things that we've been able to do, though, is kind of take an environmental justice kind of lens to things, even though that there are folks at the state that are kind of trying to get away from like inclusion and diversity and justice language. We still have a lot of federal work that's being done to continue those practices. And so what we did was we were able to write some grants specifically through the Department of Forestry that just talked about the importance of Black and Brown-led organizations coming together to do work within their own communities and not having folks to just come in and, and try to do work, but stuff that we're seeing, things that we're advocating for, plans that we are creating, and they like that. And so we were able to get a $6 million grant with the Office of Sustainability as our leader to really focus on some of the intentional work, also bringing it into workforce development with Groundwork RVA. And so like bringing community members in to actually help us do the work at the parks and like helping improving, employment opportunities. And so we're looking at a bunch of different areas on how we can, affect the most change. But the other thing I wanted to talk about too, specifically to what you're talking about is access to healthcare in general. And I would be very interested to see the 40 the other nations that are above us on the scale, how their access to healthcare is in those countries, and what the barriers are, as opposed to the barriers here in the United States. So that was just something that stuck out to me, is that like, how is our access? And I know that when you talk about access to healthcare, folks are, talk about socialism and all of these words that make it, people scared, but folks are living longer in other nations because they make access to healthcare and access to medicine easier. And so it's, it's just one of those things that I think that we as a nation have to get better on. And I was having a talk with my colleague, Freddie Mejia, that leads our healthcare work here at the Commonwealth Institute about this very thing. So I just wanted to make sure I mentioned that.